Go ahead and call the monthly finance committee meeting of the Kern Valley Healthcare District to order at 1 p.m. Any changes to the agenda?
I didn't see any changes when I was reading it. It's been a few days, but
Hearing none, the agenda is approved as distributed. So everybody had a chance to look at the minutes from the July finance meeting. Corrections or changes?
then, I mean,
Let's see either. We okay sending those to the consent board meetings. All right, public comment. I don't see anybody from the public at the meeting today. So we'll move on to item E, which is the financial statements, and we'll start with the monthly financial statements. Mr. Recupero.
Thank you, John. So we're going to talk about the new month of the new fiscal year, and I'll switch over here. Page 8. Statistics for July. And we're going to start out with patient days, line 8. We had 85 patient days for the month. That compares to 115 in the budget, and last year it was 96. So a little bit slower than budget last year on the inpatient side. Moving down to the long-term care, we are also lower, 1288 for the month. Budget of 1473, and last year was 1474. So we definitely have some work to do on the long-term care. Census has not gone up according to what we have in our budget. The ER, however, has stayed strong, even though it barely missed the budget. It's pretty much right at budget. Line 32, 635 ER visits. Budget was 649, and last year in July it was 689. So we're a little bit down from budget last year in the ER, but those numbers are still strong in long-term perspective. We're still busy in the ER. Outpatient was down quite a bit, and you'll see that in the revenue numbers. Even though ER was strong, the overall outpatient revenues was slightly less than budget, and that was partly due to this line 35, where we had 882 outpatient visits and a budget of 1013. Last year was 1048. On the good news side, in terms of staffing productivity, line 44, we did keep our staffing lower, 197 worked FTEs compared to the budget of 205, and the paid FTEs on line 45 of 223 compared to the budget of 230. So that's page 8.
Question, Dave. Let's talk a minute about the average daily census of the SNF. I know we've been talking about that for a number of years now. Correct me if I'm wrong, please chime in, because you were at the meeting last night. So at our medical quality committee meeting last night, Sally implied that staffing in the SNF is good. Is that just for the census that we have?
For the census we have.
Just for the census we have, not
we're okay. She's actually flexing people off.
okay.
There's a problem with the and I don't know the particulars about it, but with getting people qualified to be admitted. It's a change. They changed the Medi-Cal qualifiers. I don't know anything about it, but that's what Sally was talking about yesterday.
So there's just enough staffing to meet like the 40 average that we have, not the 60-year break even that we would typically have.
I think that if we wanted to admit patients, we would have to have more staff. I think
we could get a couple and still be fine.
We could still get a couple.
Over.
Yeah, she is over.
Over enough that we have room for some.
Right.
So Dave, could you look into what Sally was talking about last night with this change with the
Sure.
Medicare or Medi-Cal?
Medi-Cal.
Cal, okay.
We don't have any.
I can tell you,
Okay, Barbara,
Go
I'm
ahead,
sorry.
Barbara.
it's not Medi-Cal that you go through now. They have a Medi-Cal HMO. You have to go through the HMO to
That's
get
what
the
she said, it was
call.
an
Yes.
HMO, that's what she said, yeah. you're
Oh,
right.
yeah, okay, that makes more sense. I was trying to think of, the state didn't have any new regulations, but each health plan will come up with their own criteria, and we just have to adjust to whatever that new criteria is. My guess it's different for both the two health plans that we're dealing with. Each one has their own set of rules of what it takes to get a patient admitted.
So
So-
Barbara, have we made those adjustments in our admission process?
You would have to ask the SNF. They're the ones that do that process.
Okay. That's the question we need answered.
Yeah, okay. I'll be glad to follow up on that.
Dave, is that in the contracts with the HMOs, the criterias?
Yep. That's that's part of what's in those contracts with the Medi-Cal HMOs.
And are those huge contracts?
Yeah, they're very involved. That's just one small piece of many pages in each of those contracts. That's something that if it's not acceptable, maybe that's the first step in the plan is for us to cancel those contracts and to tell them that we're not going to renew them until we make the admitting process easier. If that's in fact what we have to do.
Then they would pull all their patients because Medi-Cal
Exactly.
wants them in an HMO.
Right.
Yeah, we can't do that.
So can
That's-
we,
My point-
can I
my
get
point-
a, Go ahead.
My point in saying what I did is that's the only leverage we have.
That's
well, that's kind of like, that's not leverage, that's like death to us.
That's like shooting
So
yourself.
hopefully we can use some negotiating skills, and if there are certain stickler points, make some tweaks on it.
Can, I would like to see a copy of the portions that what the criteria is, John, I would like,
Yeah, that'd be good to-
Uh-huh.
so we would have that information.
Sure.
Because if we're having to follow certain criterias that are different than, for the Medi-Cal, they're usually the long-term care ones, then other people are having to do the same thing, so everybody's tweaking it, so, yeah, I think we should see that, and maybe the whole board would like to see that, because we need to know, we don't need just one person or two people to know, we need to know so that, I mean, because we could all refer someone to the skilled nursing facility, but we want to refer those that are appropriate and not get somebody's hopes up and then find out the person that's doing the accepting will accept or not.
Absolutely.
Have we ever sat down and had these like strategic meetings, maybe weekly, for how we can, if I'm speaking out of turn, I'm sorry, but it's just an idea that if we had maybe weekly strategic meetings or bi-weekly strategic meetings for how we can grow the census.
So I know that we had to change all of the residents we had over there to this newer qualifier. So we have made the effort in that respect, but the people who need to be admitted have to change their Medi-Cal to an HMO Medi-Cal before they can even be considered to be admitted. And that's, I think, is that Barbara, is that right?
I believe Medi-Cal is making a lot of people go to the HMO, but
Right.
yes, they have to be an HMO patient. But I don't know if that precludes you starting them and they can't switch over.
Be transitioned before,
Right,
Right.
but our SNP census struggle predates the HMO.
yes, it does.
But these are all.
But that was also staffing related, and we just graduated 7 CNA students, and
Right, and
But
plus it
that's-
used to be, with the Medi-Cal, it wasn't that big of a deal as far, but we had the knowledge to do the HMO portion of it. I mean, you gotta get the authorization, prior, or as they're being admitted, or know, some written letter that is coming, because we had to have verification of financial before they were
Right,
admitted.
right.
So we even, back 100 years ago, I mean, people wrote and put them in private pay until they could get the Medi-Cal approved, and
Right.
then, there was different steps that we took. So
I
yes.
believe you have to have a physician referral entirely before you can even begin to admit them. Has
What-
something to do with their primary care physician.
Referring them.
Uh-huh.
Well, but if they're coming from home, we just need to have an accepting physician.
No, I think you have to have their physician referring now. I think that's part of the new stuff that they have to do.
Okay. Okay.
Thank you, Barbara, for that. That's good information. And I will
Carrie, I'm
follow
sorry,
up.
You got cut off.
Yeah, I got
Yes, you did. Go ahead.
Well, I've just, I mean, since-
We've
Agreed.
not had a committee like that that's been focused on strictly that.
because it's a big thing to tackle, obviously. And as long as I've been hearing about this, SNF census has been a point of discussion. And so, if there's some unified effort to tackle this big problem, maybe that would help. I don't know. It just seems like, because there's so much going on and there's so many
Yeah,
moving parts to get
there's a lot of components to it, the recruiting, the marketing of it. I mean, there's various.
Just so that everybody's in
aspects of it.
communication about, okay, we have this one particular and I don't know enough about
Sally's
it to speak,
comment
but
was that she has 17 people who are needing to transition to this HMO, right? Didn't she say that last night?
Yeah.
And
Waiting to
so-
come in.
Yes. So that's an.
I don't think there's
comment.
17.
Okay, I'm just telling you what Sally said.
So usually we stay out of clinical criteria for admission types of meetings, but I can get involved if this committee wants me to make it a financial committee. It's all, we can, I think it makes,
I think that, I think it's a good idea. Carrie's got a great idea as far as keeping the ball rolling and not letting it slip through the
Or
cracks.
keeping it high on the radar.
Keeping it on the radar. Yeah, I think you've got a good plan, a good comment, and
The team used to be, I mean, it was admissions and social services,
DON.
DON,
Right.
MDS nurse.
physician
It's difficult to get
most of the
them.
time.
Most of
They're
the time,
invited.
but we
They're
had, whoever the directors were,
Right.
if we got them qualified, and for long-term care, it's still a skilled nursing, so they still have to have something that the nurse
A
has to
skilled
do
need,
within a
right,
certain amount of time. But it was a smaller multidisciplinary team that would make the decision.
Right.
And
But I think there needs to be a piece of finance in that meeting as well.
yes.
Yeah.
Well, and we would get Jeannie used to run it.
Right.
She would say, yes, they have it, no, they don't have it, they verify that they had the income and stuff,
Okay.
the insurance. So, and that was all part of the admission packet, we checked it off as far as we went, and.
Maybe a checklist too, to guide that meeting. Because that could direct who is participating in that meeting.
I mean, we have these, a number of items on this strategic plan. I don't know, 50 or something. I mean, they're crazy. So maybe taking some of those items on the strategic plan, this being one of them, and create more of like a focused thing for SNF census. The master project, obviously, and then Dave's RCM meeting. Like those three seem pretty huge to me. Maybe we could focus on some of that stuff.
They're
all big,
need
but-
big money too.
Yeah.
I mean, that's a.
Yeah, we're at a loss. We don't break even till 60, it used to be
60,
62, 64.
for every 10 patients we can add in our census, that's $1 million to the bottom line. So that's
does that mean
the
that-
net.
And I will
2.2.
say though, that the staffing and the expenses are down also. So on either side of that, you're right. I think we need more census.
Yeah, and one of the things as far as marketing and stuff, like I have mentioned before, there are discharge planners, case managers, whatever.
Right.
Social services in every facility,
Yeah.
and we would send a fax. We have female, 7 female and 4 male beds.
When we had a person in that office, Tracy was calling all of those individuals at other places. Robin Gray calls those places as well.
Yeah,
You do
So,
have to be careful because sometimes you'll send out like, hey, we have beds, and they'll be like, we have 6 train wrecks waiting for it.
yeah, but then
You still have to clear them.
You still have to
make sure
clear
that
them,
they're
but they
appropriate for your
know.
facility.
people,
Right.
Have
they know where
availability.
their beds are available and stuff. And then we can meet their needs or we can't, but it has to start somewhere. So, and we do need to build that up. And I think a team would be,
just an ad hoc team to pull together with a multidisciplinary, so that we can all hear about what we have on the radar.
Absolutely. I think that's a good idea.
That's a good, well done.
Thanks. I tried my hardest just then.
Yeah.
Do you still want the detailed criteria from the health plans? Do you want that next time?
I do, please,
Yeah.
or if it could be emailed to us.
He's really just funking for a job, and pay raise, so you can watch this.
Oh.
I have a job.
Got one.
I
could
just
do it.
asked Debbie in the billing about the Medi-Cal patients. We only have 5.
Okay. 5 pending.
5 that are on Medi-Cal, the rest are all on HMOs.
Okay.
Oh,
I
okay.
don't know if they're in the process of switching over or not, but currently there's only 5 on Medi-Cal.
Okay.
Okay. All right. Thanks, guys. Sorry to get off track, but I think it's an important topic to talk about while we're going
Oh,
over
absolutely.
financials and the census. So, okay, Dave.
So we're looking at the graphs now, page 10. Financial strength index still high at 423, even though it is down from last month. We are, as far as our positive takeaways, like Mark was alluding to, we have the month we were much lower on expenses, so we did cut back on our expenses 5.7% lower than budget. That's a positive takeaway. I spent a lot of time this month. Actually, I spent time with a new consultant that Sally found to help her on some of her issues with census. And she referred this person to me, and I've spent at least 20, 30 hours with this person, giving them a lot of information and numbers. So she's really excited about using this person who is a former SNF administrator who knows the SNF business better than myself or Tim, to really give her some advice on how to improve the department. So she's reaching out, trying to make improvements and trying to find people that can help her. I spent time with her on that, besides the time I spent with the HMOs on negotiating a new amount that we're going to receive this year on our rate range IGTs. Pleased to report that number is 2.5 million higher than it was last year based on our negotiations. So that's in amount above budget and above what we had last year for that particular IGT. And that should be coming in the April-May timeframe of this current fiscal year. None of that's factored into what I've presented today for the July financials, because it all happened recently, but it is good news that should not only translate into better results in terms of bottom line and cash for this current year, but also future years, if that creates a better baseline for what gets paid in future years. As they've reallocated resources, there's no longer there's one less public hospital involved in receiving these funds to Tehachapi, and we did a pretty good job in getting a fairly high percentage of what was redistributed. So I was real pleased with that. The other positive news is we thought we had a 2% denial on a letter we got from Medicare. It was a quality cut, and apparently the way they worded it was worded misleading. And they said it was kind of like you may have had this 2% cut, so please submit an appeal. But when we found out, we reached out and they said, no, there was no letter in our other file that said we actually did receive a cut, so it didn't apply to us. So we were pleasantly surprised that that was also positive news for the month, that we had reported to another committee that there could be some losses as it relate to a quality cut, and that did not happen as what we were concerned about. We did receive an improvement in accounts receivable collections. Our payment percentages have gone up, and our old account balances are down significantly for accounts greater than 180 days have all improved. On the negative takeaways, our cash did go down. Our AP balances are higher. And I just like to make a brief comment about what AP, along with some other things going on in the finance areas. We have been significantly hampered by extreme staff shortages over the last 3 to 6 months. We've been without an AP clerk who is on extended leave, and also a payroll coordinator who's left, and we tried replacing those positions, and it took longer than we had hoped for replacements to come in and get trained. So we're seeing some of that resulting in some of our numbers not being quite as good as we'd like them to be until we get back to full staff in some of these areas. Gross charges, I'm sorry, yes.
It's okay. And so because of that, I have an understanding that we missed a deadline on a swing bed.
Yeah, that was
payment.
what I was referring to, the 2% cut. That was not a real.
It
That
doesn't
was-
look like that's gonna be a problem for us.
Okay,
I had Omega check into that.
okay.
Yeah.
Okay, well, the reason I brought it up because when you had mentioned it, I didn't hear it
Yeah.
specifically
Yeah,
on
we
the swing
We
bed.
brought it up at a different committee and it looked like it was a problem at the time, but new information came out. In fact, Mark helped me today with his research. Who was it that you talked to, Mark?
Omega, she's our MDS coordinator. And she showed me where this was at. And I can show you later.
Okay.
Yeah.
All right, thank you.
So it got reported then to the right agency?
No, what I was trying to do is make up for the fact that their deadline, which I got the letter like halfway through the 30-day period, and I did miss the deadline, and that's what we had a report at the committee. And thankfully, we weren't really in violation to even have to do the report because of the way they worded the letter. I think I have the letter here somewhere. The way they worded it,
That on my shut off notices.
it says, see, how does it?
And what committee was this reported to in the beginning?
It was, I believe, UR committee.
It was a compliance committee, compliance.
Or
oversight.
compliant, no, it was compliance, that's right. Anyway, I'm not seeing exactly where it was misleading, but it just made it look like we were already in violation, but it actually was, you may be in violation is really what they meant to
I'll
say.
show you the letter too then. Okay. Omega showed me.
Okay,
good.
so if it's taken care of and we're not at a loss,
No,
okay,
so that was some more good news as we looked into the details on that. And by the way, we are going to have things that happen throughout the year, good and bad, and I'm going to continue to be transparent and report everything, whether it's good or bad, and we're going to work hard to fix anything that doesn't go perfectly. We want to make improvements forward. In this case, there wasn't anything that had to be dealt with.
Dave, real quick, number 3 on the positive takeaways, real quick, you were talking about old account balances.
Yeah.
Is that's the AR balances from 2020, the ones?
Yeah,
Okay.
those real old ones are finally cleaned off our books.
Are
And
they completely cleaned off, or is the balance substantially lower than what it was last fiscal year?
the report I looked at, which is the end of August, it'll be all completely done. Most of it was done in July, and Debbie cleaned up the rest of it in August. So when I report next month, that will be the case, that there isn't any old of those skilled nursing ones from 20 and 21 that are still in the system as balances.
Okay, good, thank you.
So let's go to the profit loss. Let's go to the balance sheet. You can see AR last month was 27,051,051, dropped to 25,774,000, line number 4. That's a 1.2 million improvement on gross receivables. On the liability side, where we talked about staffing issues, you can see how AP went way up for the month, 1.3 million up to 2.4. Besides the staffing issues, we did have some timing issues when we had to get treasury bond bills matured and make withdrawals so that we had enough operating cash to pay some invoices, and that took a little bit of time. So we're getting caught up, and I expect to see in the next quarter to get our numbers back down to where they were before in accounts payable. The profit loss statement, line 6, total gross patient revenue.
Dave, you keep kind of going in and out. Can you kind of stay on your screen? Did you kind of cutting out a little bit, your voice?
Okay, on the next page, the profit loss, total gross revenue of 9,584,000 was almost $1 million below budget, 9.3% on line 6. That 9% below budget, thankfully, on our staffing on line 14 was also 9% less we had on salaries. So we did flex down on the salaries, as Mark was intimating. That was enough to kind of bring it to a break-even month. If you look at the very bottom, we came close to break even with a slight net loss of 18,000. But pretty close to break even because we did keep our expenses 163,000 below budget on operating expenses. Some of these line items where you see red in terms of higher than budget was a function of some construction projects, paying Greenbow and for laundry and other purchase services on certain big construction projects that got expensed instead of capitalized, causing a higher amount for purchase services. And also similarly on leases and rentals, we had some higher plant and maintenance expenses related to construction projects on line 25 for leases and rentals. So those are more of a function of the higher amount of work Bob's doing and some of the projects he's working on, and some of the expenditures being high for the month as a related to that issue. So overall, we are expecting to see a year at or above budget, even though we're not performing as well in certain areas like skilled nursing as it relates to volumes, because of other things that are more than offsetting those negative impacts as it relates to negotiating better third-party agreements for IGTs, and those types of things are more than offsetting the lack of performance that so far we're doing. We are putting a lot of resources in to helping Sally out in her desires to improve the department, and bringing in outside help and also setting up committees might also be an additional correct move in terms of prioritizing our resources and focus into areas that'll make the most difference for us financially. So that's pretty much all I wanted to report on today.
Any questions for Dave?
Nope, I've already asked mine. Thank you.
So did I. Harry?
I was thinking one thing that might be helpful too, and I know we used to get it, was department budgets. Like we used to get just a printout of where we fell.
Productivity line, yeah.
Yeah, and where we were sitting, like in terms with what our budgeted expenses were throughout the year and where we're sitting year to date. I don't think we've got those for a while. I know it kind of helped me determine what to do. And so I don't know if it would help other departments It's helpful for me.
Yeah, I can certainly do that. I have those reports ready every month. So it wouldn't be hard for me to start sharing those.
Yeah, if they just went out to the managers in an email every month, I think it'd be.
I already know what mine's gonna look like, so happy to see it. Yeah. I mean, it does
Yeah, I've got my spreadsheets all built for all that, so all I'd have to do is send them.
look good ever.
Med-surg.
Yes.
Maybe we brought that up earlier in the year about bringing that back,
Product line
the
summary.
product line. Are you okay with
Okay,
bringing it?
and
I'd actually, yeah, like to see it. So maybe starting in September, we can start looking at it. And
Okay.
include it, if that's okay with,
It's fine.
Okay.
Yeah, I think that's great. Makes sense.
sounds good. I can do that. Anything else?
I think so.
okay, thank you, Dave.
I should probably, there was a meeting yesterday where I brought up Gary Hicks. I did have a brief conversation with him after the meeting. He's willing to come out for the next full board meeting if that's still a preference of the finance committee and the rest of the board members to just kind of introduce the concept.
Can you,
Would we have to pay for him to come out, or would
No.
it be better
No, it
for?
would-
He could zoom in too.
He could zoom into it. He's not gonna charge us for it.
okay, because he's in Utah, correct?
Yeah,
Yes.
he has another meeting right close by to the following day, so he's thinking he can handle both in one trip.
Well, I'm completely in favor of him being at the next board meeting. I think that's important.
Because what we're doing here is we're introducing a new way of thinking as it relates to the big project that we want to make sure it's fully funded, even with a FEMA grant. And he'll give you the ins and outs on it, whether that's a good or bad thing.
Okay. Yeah, no, I'm totally in favor of him.
Yeah,
being
I
at the
am
board meeting.
too. Thank you.
Okay.
The next report is the local aging report. Barbara, did you have anything, or did anybody have any questions on the aging report? Usually it's pretty.
I don't have anything to say about it unless somebody has questions. That was run as of 8/21, so
Okay. Yeah, looks good.
How come we're behind 60 days on 77 cents?
that's a credit.
Yeah, that's
Okay.
a credit.
Sorry.
It's not.
Well, I want it.
It will be offset in their next check.
Okay. Thanks, Barbara.
But,
You gonna come back to exchange there one day?
okay,
Perhaps.
thank you, Barbara.
I'm president this year.
Are you?
You cause trouble. All right.
You're an instigator.
So is Carrie's, yeah.
Yeah, I know you.
Thanks, Barbara. Next item is the contracts on page 23.
And they're all listed. You had the list in your packet. Does anybody have any questions on any particular one?
When I reviewed it, no, nothing stood out that I had any questions about.
So either. Good. You okay with sending that to the consent,
Yes.
Catherine? Okay. Okay, we'll go to consent for. Okay, moving on to the CER requests. Mark, I guess you're gonna do most of these, huh?
This is one for me.
I saw
The
the
first one.
system and I was like, oh, did I do something I forgot?
This is an addition to our electronic health record in the ER. We have been using barcode scanning for medication administration on Med-surg for now 3 years.
Yeah, wow.
Quite a while, and we've been able to, I maintain about a 92, 93% accuracy rating. Nurses are doing it very, very often and it works really well. They have an option to, and the MERP committee, pharmacy and everyone else in that committee has been looking at barcode scanning as a way to reduce more medication errors. The ER has a few of those, and ones that have been identified as barcode scanning would have not allowed that error to happen. So it's fairly pricey. The initial outlay is around $15,000 just for the software upgrade, right? Is that what it
It's
is?
just basically giving us access to something that already exists in the system.
Right. So
They charge us for it.
they charge us, and then there's a monthly fee as well. The initial outlay is the $15,000 amount requested. And then we're also requesting the $1187.95 per month, which that adds to our T-System monthly dues, right? So,
I have a question, Mark. Just,
yes,
can I ask a question?
yes, absolutely.
Our scanning, is this just pushing the information to the medical record? It has nothing to do with charges.
It does not have anything to do with charges, no. It just simply is a way of documenting the administration of the medication at the right time, the right patient, the right route, the right dose, and the right something or other. There's 5 rights. I only thought of 4 of them. I haven't done it in 13 years.
Barbara, point of care charging is something that we're exploring right now. So this wouldn't be it, but I know we talked about it before.
Don't rattle that cage yet.
We're not rattling.
Well, yeah, but then are you going to have to do that twice? The nurse is going to have to do it twice?
No, the charges for medications are pulled out of the Pyxis.
Fix this.
So we don't even, this doesn't have anything to do with that. What Carrie's alluding to is we may be looking at bringing in a barcode scanning for supplies. But
Okay.
we haven't even gone down that road yet.
I would want you to bring that before the RCM
Yes,
committee,
it's medication administration.
so that those departments that are affected can review, whatever we want to do. If we want to automate the charging a little bit more than we are right now.
Yeah, is this the best deal you could get us?
It is, unfortunately. T-System, we could switch
And
to,
it's not a Sally, the salad maker?
this is not a Sally the salad maker. This is
Oh man, I wish it was though. I miss her.
No, but we didn't have her very long. Took us longer to get it than we had it,
That is true.
but I guess it was more like a rental fee than a.
Apparently, yeah.
So,
Yikes.
okay, this
Well, are you okay with sending it to consent?
is in consent, yeah.
Item 2 is the emergency department position agreement, Dr. Person. I think it's not.
So I'm told that we are just bringing Dr. Carslin up to par with the rest of the physicians that are doing the same job back there. And so Dr. Carslin's agreement hasn't been looked at for quite some time. So that's what we're doing with Dr. Carslin, just adjusting his rate.
And he's had peer reviews and everybody thinks he should be getting it.
Well, I didn't do any peer reviews because I'm not a physician. But he seems to be, they never talk about him in the med exec, and he's always here when he needs to be here.
Oh,
Picks up the rentals.
He picks up,
Really?
yeah, so he's one of the ones that we want to keep.
keep on.
He's a good guy.
He's a very nice man.
He did, however, get us in trouble with a little bit of, he was wearing his PPE walking down the hallway.
But he also wrecked a car in the canyon and had the paramedics drive him to the hospital, and he worked with them.
Not real smart.
No, he knew there was nobody to cover.
Oh,
He was fine. He just needed a ride.
it's perfect. Now you make me feel bad that I didn't make it to the finance committee that month. Car accident. Okay,
I'm okay with sending that to consent.
Yeah, I think this one's fine.
also.
It's the same with Dr.
Dr. Newell is coming back to work for us. And his rate is the same, but we're just renewing his contract.
It was in that one that been sent to Kathy.
So,
And then item 5 is the Whipley Letter of Engagement Day. 47 to 50.
Thank you. On one of those pages is a detailed list of prices for the new cost report. Every year, this is the time of the year between now and the end of November when cost reports are completed. And we've had several years. I don't know, Barbara, how many years have we used Whipley?
It's page 48.
Quite a few.
Yeah,
We've
at
used
least
them for a long time.
at least 5. They've done a good job. I was a little.
Prior to that, we were using Paul Failot, so it's been that long.
Yeah,
oh,
and
Paul
Paul
was
is.
good. Paul was a good guy too, yeah.
So
It shows how long you've
we've
been.
got a renewal opportunity here. It's a little bit of a sticker shock for me. These numbers, for example, the main fee of 12,300, that's up. Last year it was 11,200. So most of these new prices are 10 to 12% higher than they were last year. So I wasn't real thrilled with that. But there's not a lot of other firms in California that do cost reports that know small rural facilities. They've done okay with us. It's probably a little bit late in the game for us to make any changes, but I did want to bring this to this committee so that you have an opportunity to see some of the specifics of what this contract involves. It's a lot of work for the finance department because all these work papers require a lot of documentation that we have to present to them. A lot of departments do special reports to put it in the format that's required for cost reporting purposes. And every year it becomes a big project for Barbara and her staff to prepare. The email I got from Barbara is, Barbara, you sounded like you were okay with renewing this.
Oh, yeah.
But we've had a good relationship with Whipley over the years, so I am recommending approval, even though I'm not real happy with the numbers.
You're just not happy with the fees or
The fees, yeah. The actual results, we actually found somebody else at Whiffley that does SNF cost reports. Has a really good reputation, and we're going to ask them to use that person on the SNF part of the cost report, and that'll make a big difference in terms of our payment.
oh,
Oh, we're back.
sorry, cut out. Oh, that was.
Can you still hear me?
Yeah, we got you back.
Okay, so anyway, yes, we'd like to move forward with this contract with Whipfly, if it's okay with this committee.
I have one question where it says you authorize Whipley direct access to your accounting systems when requested by you or is deemed necessary by Whipley.
Have we done that before?
No,
No, that's a new one on there. You know, I could scratch that off before I sign it and send it back to them.
You can't sign it and send it back. It still has to go to the board, so just
Oh,
because
okay.
they pass it along here doesn't mean it's done.
Oh, thank you for that. Okay.
Yeah, I mean, I need to understand,
What that means.
well, I mean, on the surface, it's certainly a red flag, but I'd like to understand more in depth what that means and how they plan on obtaining this access and what access we are required to give them.
Good point. It may be one of those boilerplates that they have in other contracts that they don't use for us because we give them everything they need.
Either way, if we can remove it, that's best, or at least explain it better.
Yeah, I mean, look at the other side of it. Yeah, it's telling you what you further agree to manage such access and understand that you are responsible for providing that access in a sound and secure manner that does not compromise your network or systems.
But that, if we were to do that access to our system,
That's how we.
that's how we would apply it, but I just need to understand what they're hoping for here.
But this is
Okay.
something we should probably work out before we put the board packet out, so we can have the revised agreement if we revise it in the board packet.
Yeah.
Yeah, I'll give them a call tomorrow on that and we'll get
Okay,
that straightened out.
And I'm happy to talk to them too, so that I can understand directly what they're wanting, at least on that line.
Uh-huh.
So we're gonna send it to consent with changes made or bring it back to this?
you guys could send it to, we could put it on new business too, so we can still discuss whether or not there was
That's
a
what-
change or like what it
That
means.
way, we can get clarification on what
Right.
Harry's concern is and any other.
When does the current contract expire?
I did not bring that with me. I can look that up for next time. I believe it's either at or beyond expiration already.
Because the contracts renew every year because it's for a particular year's service.
We clearly have the window is pretty much closed. We have to get going on the beginning stages of this New Year's cost report. So we do need to get somebody on board soon.
Well, it's just a matter of clarifying that statement about access.
Yeah, that could just be a 5-minute phone call.
Right.
And then the paperwork updated before it's sent.
Well, we may not
Well,
even need to
if
change
you
it. I just.
revise one, then you
Yeah.
would get that. If there's no change, then Carrie can explain to you why it wasn't necessary to make a change.
Okay.
So we'll put it on as new business, just,
Yes.
okay.
Okay, with that, there's nothing else on the agenda, so we are adjourned at 1:46.
Excellent. Nice,
Bye-bye.
nice, that's a record.
Probably.
Yeah, maybe not.
No, I think I had one less than an hour.